And the minutes, we have minute takers. So Kezia and Frida will be our rapporteurs for the sessions, but then different sessions will be moderated by different people. So maybe I should just share the agenda. So I don't know if everyone is able to see the agenda. So we'll, Dr. Jacob will give us opening remarks just for 2 minutes or so. Then I'll be making a brief presentation on the proposed migration rollout plan. Then we'll give a chance to Dr. Mudoka to take us through a guidance on the individual data verification and why it is relevant and important during this particular process. Then Patrick, our QA, will be taking us through the data validation and verification process, control migration testing feedback, and also Evans will take us through the assumptions during the EMR migration. Then after that, we'll have Juan moderating this session, where we are going to have now partners giving us the feedback based on the testing that they carried out from last Friday up to today, as well as the individual partner plans on the migration mass rollout. Yeah. So then finally, Joseph Junge will be taking us through the closing remarks and also defining the way forward. So in brief, that is going to be our agenda for this particular meeting. So maybe without wasting time, I guess we could just begin. So I'll just give Dr. Jacob a chance to give us brief opening remarks. Welcome, Dr. Jacob.
Yeah, so thanks, Bernard. Since this is a technical meeting, I will not take too long. I just want to say that, first of all, I appreciate everyone from where we have come. Secondly, is just we are basically transitioning to actual migration by focusing on the facilities that are within phase 1 of the migration, basically preparing these data sets not only to match, to be ready for reporting, but also to basically start the migration on the desk as we refine the tool together with you. We are hoping that as we move to the next phases, we'll be learning a lot of lessons from a few sites before we expand to the larger sites. I know in the forum from the last few days, we have been seeing increasing levels of concordance, but now the task ahead is to drill down and find out what really is the cause of each in a much more structured way that can be actioned, but also to document issues that cannot be solved by changing the toolkit, but can be addressed by looking at the underlying data a bit differently and getting consensus on the way forward. So that is all I'll say for now. I look forward to a productive session. I'll take it back to Bernard by saying that we feel like we are part of you and you are part of us. So feel free to open up and give us feedback where appropriate so that we can be able to address it as we move to the final legs of before we end up at a facility and attempt to migrate. So back to you, Bernard.
Thank you, Dr. Jacob, for those very good remarks. So I'll just take a few minutes and take you through a brief presentation on the migration plan. So I'll just share the screen one more time. Could someone confirm if my screen is visible?
Yeah, it's visible.
Okay, thank you. Yeah, so so I'll just take you through very few slides where I'm going to share with you the migration rollout plan, then the justification for the controlled rollout. Then I'll also share with you the criteria that was used to come up with the facilities that are going to participate in the control phase. And then finally, I'll share a list of facilities that are going to participate in the controlled phase of the migration. So basically, to start off, so we are going to have about 4 phases of migration according to the plan. So initially, we're going to begin with the limited number of facilities under the controlled deployment, where we are going to focus on 16 facilities to migrate. From there, we'll move to the second phase, which is the mass rollout, where we are going to have a number of facilities, and this will be led by the various service delivery partners supporting these facilities. Then we'll move to the third phase, where we are going to now focus on the partners who are supporting the customized version of IQCare, not the standard KenyaEMR version. So these are about 136 facilities. And then finally, we'll be looking to support the ASAL counties, which are about 27 sites. So these are distinct phases that we are going to go through as we are planning to roll out the migration. So it will be important that all the partners understand which phase they fall under as we go through this particular migration plan. So some of you might be asking, why controlled deployment? Why are we starting the deployment from a controlled point? So it is important because out of about 735 facilities that will eventually migrate, we are narrowing down on about 16 facilities that are going to act as demonstration sites, that are going to act as the site that we are going to learn our lessons from. So this will be limited number of facilities, as I've already shared with you, where we are going to you are going to conduct the migration, but under very intense scrutiny, because we want to kind of document and learn everything about the migration and be sure that when it is ready for mass rollout, everything will be as accurate as possible when that time comes. So this is the reason why we are actually starting from the controlled point, and this will help us also in the documenting the migration process, and also with a couple of lessons that we'll be able to learn, all of us. And also we are looking to perfect the migration toolkit before the mass rollout, which will be very important again, and also to build your confidence as our stakeholders in the migration process. When you see that your concordances are matching well, you have 100% concordance, and you are sure that everything is able to migrate as it should, then you'll be more confident to move to more facilities and do the migration. And lastly, we are doing the controlled deployment also to provide a learning opportunity to you as our service delivery partners. So how did we come up with the 16 facilities that I'm talking about? So we had very intense engagements with the partners just to find out which of their facilities were suiting the criteria that was developed, just to ensure that we get the right facilities to start migrating from. So we had a list of criteria that was developed just to guide on the selection of the sites. So one, we were looking at the facilities that are using care and treatment services optimally, and also in terms of service delivery and also in reporting. We were looking at the facilities with very good data quality, and we were looking at about 90% based on the last data quality audit that was carried out. Then the facilities with the moderately low to medium volume facilities, as per the service delivery guidance, this was being guided by the the delivery partner. Then the facilities that have trained and active EMR champion, also this was advised by the service delivery partner supporting those facilities. And we were excluding facilities that were implementing other modules like the HTS module. So they were dropped from this particular iteration. Then we were also looking at the partner, whether the partner had very good existing KenyaEMR experience, particularly for the partners that were supporting both KenyaEMR and IQCare. So we also included those. Then we also included the facilities that were running KenyaEMR version of IQCare to participate in the controlled phase. So if for the facilities that are supporting other versions of IQCare were being excluded from this particular iteration. And then lastly, we were considering the partners with the demonstrated ability to support KenyaEMR. And this was demonstrated especially during the migration testing. We could tell which partners were able to independently support, install and support the KenyaEMR platform. So those particular partners were also identified and included. So this is the list of the 10 partners with a total of 16 facilities that will participate in the controlled phase, phase 1 of the migration. So we have CHS Shinda with 2 facilities, CHS Naishi with 2 facilities, CHS Tegemeza with 2 facilities, UMB Pact and Eleza, which also have 2 facilities. Then we have UMB Timiza with 1 facility, Afya Nyota ya Bonde proposed 2 facilities, Afya Kamilisha with 1 facility, KCCB Cup with 2 facilities, AMREF has 1 facility, and lastly Afya Jijini also has 1 facility. So that is a total of about 16 facilities that are going to participate in the phase 1, and these facilities closely match the criteria that was defined. So when it comes to the migration approach, so we have a proposal of how the migration should be approached. So because of this COVID reality and the COVID pandemic, we have proposed a boardroom migration with the very precise planning to minimize the disruption of service delivery on the day of migration. I think for all the guys who have participated in the whole migration process, setting up the migration environment, doing the actual migration, and also looking at the data validation, you've seen how much that time, the amount of time that takes. So to minimize the disruption for that length of time, we are proposing that you could do this comfortably from the boardroom, then take back at the facility the database that you just restore, and then it works. And also that will also help in terms of minimizing the contact with the facilities as a way to prevent the COVID contacts. So in conclusion, we are proposing to do the migration in phases, as I've already shared, commencing with a limited number of facilities. And those facilities have been selected by the respective service delivery partners in close engagement with our SECA team. In terms of the approach to take, we are proposing a boardroom migration due to the due to the reasons I've already given. Also, in terms of documentation of the feedback, we have already shared a standard validation template, which we are also looking forward to get your feedback on that particular tool during this call. But then once it has been perfected, this is the standard tool that we'll expect all the partners to document their feedbacks on during the migration. So all in all, that is the summary of the plan that we've come up with to guide the EMR migration that we are planning to do. So thank you very much. Unless there is a question, so if you have questions, we recommend that you type them in the chat area. We'll be responding to them during this particular call.
Yeah, thank you, Tieno. I think for me, I just want to add on to what you've said, that there's going to be a lot of lessons we hope to learn, both on the validation tool that you have tried to use over the weekend, but also on the dealing the controlled deployment, because we know you have so many sites and other partners are not part of this call, but we want now to be the ones that share our lessons with them together, so that when we come to the mass deployment, we are able to say with confidence that migration can happen with 1, 2, 3, 4 issues that they have to pay attention to. The second thing is that, which Otieno did not mention, is the timelines for phase 1. I think it would be nice to migrate the site as early as possible, so that as we move towards the end, we have already learned all the lessons we wanted to learn in the immediate post-deployment period. So I think the discussion will be very rich around the toolkit, the validation tool, but also how the migration will happen during the controlled phase. So I'll take it back to you, Bernard, to ask the next presenter to come back.
Thank you very much, Doc. So the next presenter, we are going to have Dr. Mudoka to take us through the individual data verification process and why it is important. Dr. Mudoka, if you are in the call, kindly take it away.
Thank you, Bernard and Tim, and welcome to my short presentation. I'm projecting just a couple of slides to highlight this. Bernard, you can confirm for me whether you have been able to receive the shared screen.
Yes, I can see the screen.
Okay, thank you very much. So most of the times we realize that when we are doing the migration, a lot of focus and a lot of discussion is on the indicators and the concordance or the variance between the indicators as computed in previously in IQCare and now in KenyaEMR. But there's also a lot of focus and a lot of importance with individual data elements or variables that are of importance as we move. And I think we shouldn't lose sight on this. And I'm just here to make a short case on why we need to focus a bit more on this particular one. So a bit of background is that we know there are two streams of reporting. There's the aggregate reporting and there's individual level reporting. And these are the streams in which data is usually transmitted, whether you're using an EMR for retrospective entry or as a point of care. So many facilities will do aggregate reporting either to the DATIM or for DATIM purposes as a donor requirement, or 3PM, which is similar, or maybe to the Ministry of Health through the KHIS, or maybe some ad hoc request. Maybe you're doing a semi-annual or some form of a report or continuation application, and you need to use aggregate indicators to be able to make your report. And this is very important, especially the verification of this. And its relevance to migration is, and a few things to consider, is that you realize that some of the indicators we spend a lot of time discussing, things like TXCAR or the number of active patients, TXML, and things like that, only use a certain selected variables to compute these indicators. And we cannot understate the importance of validating whether these indicators agree, whether the TXCAR in IQCare and the TXCAR in KenyaEMR is the same. It's extremely important to make sure that they align, or at least they're within the variance. And as we do this, I think through the exercise and the discussion, we have been able to acknowledge that there may be some subtle differences in which the two, with the same indicator is computed between the two systems. And sometimes that could be explaining some of the reasons we see in the variability. If you're calculating the TX car, the assumptions made or the variables used or where they are selected, either the pharmacy or the clinical TCA, may make some of the differences that we are seeing. But my focus mainly today is on individual level reporting. And specifically, this relates to those individual reports that are sent, or patient level reports that are sent to the warehouse routinely, or at the very least every month. The individual level records that go to support the case-based surveillance, or some ad hoc requests that we receive either from Global Fund, CDC, or the Ministry of Health for national planning, or just clinical encounter patient summaries. And these are things that you may not routinely do when you're reporting to, when you're doing a DATIM report or a KHS report, but they're important because they help us to be able to understand the epidemic. So specifically, when you look at this migration, all variables are relevant to a patient. And we know the requirements of disposal of medical records. Records ideally should be kept by international practices, can be destroyed 10 years after a patient has been discontinued from care. But we are dealing with a disease where the management of a patient is in perpetuity. You're not about to stop. So we have patients who started ART treatment sometimes in 2004. There are some clinician notes that were made that there's some patients who were put in some treatment maybe in 2004, and you may be wondering, is this information relevant to have when we migrate? And the simple answer is yes, because one, we require it for individual level reporting, but two, it's also a requirement by law to be able to keep these medical records and not to destroy them. The other thing that you'll notice is that for this type of reporting, we usually require several variables to compute maybe information, and we're using it on longitudinal manner or for longitudinal analysis. For example, you're looking at a simple indicator like treatment outcomes. And treatment outcomes is something that can change over time. So if you're looking at treatment outcome at 24 months, that person may have been lost 2 or 3 times along the way. So patient visits and even documented outcomes along the way. If someone has been lost to follow up, then came back to the program, reintegrated, and is active now, the outcomes of that person in predictive analysis in future are somewhat different than someone who has been throughout the program across. And for us to compute this, then we need a lot of those variables to be migrated as is without transformation. And then lastly, we know that the highest significance of this is the outputs that are prepared from the warehouse, like the minimum program requirements to monitor the country's response to the epidemic. After migration will depend with the quality of data that will have migrated. And we do realize that a bit of cleaning may have to be done before migration or after migration to be able to align with this. But something to keep in mind as we migrate is that we need to maintain the integrity of data before it's transformed. So my purpose of presentation today is to request you, as you confirm and as you check the concordance or the variance of indicators, also take time to look at specific variables that are important to inform the epidemic. In the next couple of slides, I've identified a few use cases on some of the most important variables that you could look at. This list is not exhaustive. I just shared it in thematic areas of how you can be able to use that data. So you look at, for example, to be able to duplicate your records, then you need to confirm the patient ID. So many a times you're just confirming that whether the patient ID is there or not. And this one is just to check whether there is any transformation with the patient ID before you migrate. And this variable is extremely important because other than being a unique identifier, it's what you can be able to use it for the duplication. In other analysis, one of the Kenya's COP19 priority is to be able to confirm with a unique identifier. And the Ministry of Health has already issued a prescribed format of how a CCC number should look like. So just to confirm that the CCC number of the patient in IQCare was migrated as is on the other side. An important variable is the date of birth, and I picked this out from the other socioeconomic and socio-demographic variables, because without date of birth, then we don't know how old someone is. Date of birth is used to capture the right age. And these has implications, especially in children, where the amount of drug that they get, the molecules that they get, is usually based on age. And age-adjusted dosage is the correct approach. Sometimes you're doing an analysis to see whether there's adherence to the guidelines. And if age is missing, then you don't know whether it's a child, whether it's an adult who is in regimen for pediatrics or the other way around. There are several variables that we use to be able to determine health outcomes, things like marital status. So when you migrate data, you may not see, you may not be looking at the indicators around marriage and marital status, but social support and treatment support information and other information around the social environment of the patients usually affect their treatment outcomes. So just making sure that you sample a few of the records and just confirm. It's not enough to know that 30% of the patients are married. When you migrate, 30% are married. Would you go step ahead and just confirm when patient X migrated, they were married? Did they get married somewhere along the way as they transformed to KenyaEMR? Who married them? And things like that. So just confirming some of those variables. Another very important variable is the BMI. And BMI, again, like age, sometimes may influence the regimen that someone is on, because some of the regimens require you to have met a certain weight limit and things like that. And BMI also involves the other variables that are used to compute that. So you can pick a certain particular date, like the last visit, and just confirm from the patient charts, are these triage notes the same as is on the other side. BMI is also important because that's what we use to determine whether someone is eligible for DSD or not, along with other variables. So just confirm, and you may not have, someone has been coming to the clinic for 10 years. You can just essentially just sample the last visit and confirm and cross-check between the two platforms. A very important use of longitudinal data is cohort analysis, and several variables are usually very important for you to be able to do this. So along with the sum I've already mentioned before, things like ART start date. If you upload data in the warehouse or in your EMR and you don't have a start date, then you don't know which cohort this person belongs to or when they started ART or not. Even closely related is whether this is a new patient or it's a TI patient. And if they are TI, which is the date? And verification in some of the exercises, we had realized that some patients are not transferring, but when you look at the KenyaEMR after they have been migrated, you may notice that a default date is already indicated. This would bring a lot of problem when it comes to analysis, because you'll not be able to tell whether patients are transferring or they're not transferring. And this also relates maybe previous ART exposure and other variables around the time of enrollment, baseline characteristics that usually migrate. If someone was started ART when they're WHO stage 4, at least at around the time of enrollment, then the same should be migrated as is. Another important variable to look at is variables around appointment data. I'm looking at the last clinic visit or a pharmacy pickup or the next appointment date. And these variables are very important because this is what we use to determine whether someone is active or they're on treatment on ART at a particular point in time. So if this information is missing or is transformed during migration, then it becomes a bit of a problem. So again, like I gave the example of a BMI, you could pick the last visit and just cross-check patient by patient, can sample a few and see whether these dates are exactly the same and they have not undergone any transformation. Another important date is the exit reason and the exit date. And these ones usually help us in determining the outcomes of a patient. Again, like I said earlier, a patient can be lost in the course of 5-10 years several times. So you just want to make sure that this information is actually captured, and you don't want to leave data behind. Some more use cases, and I have a lot of bias on care and treatment for this presentation, is monitoring the implementation of the test and start. And especially after 2016, patients started the ART from 2016 based on the ART guidelines. And important variables here to look at is the date of diagnosis and the date of enrollment. You may notice that the two platforms may be capturing this data a bit differently. And it's very important to make sure that whatever you would have looked at as the date of diagnosis or enrollment from IQCare is transformed the same way in KenyaEMR. So these dates are usually important when you compare it with the date of ART start, because you can be able to tell whether the program or the facility or for this particular patient, the average duration or the median time it's taking for someone between the moment they are confirmed positive and the moment that they are started an ART. And the difference between diagnosis and enrollment will also tell us the amount of time that is taking to do patient preparation before they start ART. Something else also to look at is around TLD transition. You look at regimen data, and you notice the two systems. IQCare was collecting data on individual molecules, and KenyaEMR usually uses the structure of the standard regimen. And just looking at when was this regimen started and the date indicated in IQCare, and just confirming that the same is transferred when you migrate. And these variables are very important because you can be able to tell for someone has been on ART on a certain regimen for how much time, and if the drug has changed, is it a correction of maybe maybe a certain molecule had been written twice, DTG was indicated twice instead of one because IQCare was picking one. Is this patient on standard regimen or not? Is this person on second line or a third line, and things like that. And even the reason why regimen is switched, you compare two time points in place, and you notice that this patient drug regimens between those two periods are different. Is there a reason why they changed the regimen that is documented? Others, we use them as independent variables. Maybe you want to predict treatment failure or something. So things like adverse events, we know it's a requirement by the Pharmacy and Poisons Board to report that, or even ART toxicity, the pharmacovigilance, to be able to monitor. If a patient had some AEs, has that been migrated? Things like ART adherence, is it captured? Things like prophylaxis adherence, is it? And you can just pick again the last visit, check whether those variables have migrated, whether it's blank or if it is documented and whatever is documented is as accurate as the source, using IQCare as the main document. Again, around treatment failure monitoring, I call this virologic monitoring. A few dates, especially this is very important because this is a very objective way to monitor the response of antiretroviral treatment. So you may pick the last viral load date and the result and compare between the two systems. Again, you may look at the first viral load date and the result after ART was started. It's around 6 months after ART start, and the results, and compare it with what you get on the other side. If lab reason is documented in IQCare, then cross-check, pick a particular viral load, and I know KenyaEMR has a chronological list of all viral loads, the same as the same as IQCare. Just compare the two and see whether you're getting the same, whether you are migrating the same thing. Monitoring IPT uptake. These IPT tables on the two systems. So IPT start date and complete status, and knowing that we have information around the AEs and the dates when these AEs occurred, or you pick a random visit, or maybe like previously what I've said, the last visit, and see, is TB screening using that ICF tool done? And if it is done, yes, no, and are the questions as answered as they were when the tool was migrated? The other one is around DSD, and there are very many elements that determine whether someone is stable or unstable. So the two systems will pick out whether someone is stable or unstable. There's a 50% chance if the migration script is correct or incorrect, that it may easily classify someone as stable when the other person is stable. But by looking at the individual data elements, like opportunistic infections, whether adherence is there, whether the person is of the right age, more than 20 years, whether the healthcare worker concerns have been documented, and now compare this with what is documented on the IQCare and cross-check, then you can be able to give a development team enough feedback to tell them, well, you may have migrated stable and unstable, but these individual data elements, there's a transformation for this variable that we could be able to look at. There are very many forms of DSD, and if it's documented in IQCare, we want to be able to transfer the same to KenyaEMR. So these are just sample of those, and then in my last slide, I just want to give some information around uptake of prevention services. We have PHDP that has an overall category, but then the individual elements, they are well documented in IQCare. Make sure when you migrate them to KenyaEMR that you actually check, because without doing this, then we'll not know if a few years down the line you're analyzing the data and you notice that some people are having maybe treatment failure or they are not programmatic attrition, then we can be able to allocate or be able to understand the rationale behind this. There's also a checklist for GBV screening at every visit. You may pick one of the visits and just confirm, is GBV screening done, yes or no? And then the elements that entail the GBV screening and things like that, have they been in correctly, just like the PHDP elements or the DSD, have they been included? So again, these are very important to just check, and the rationale is how they're used in terms of analysis and implementation of the same, because that information is what will inform policies and practice in HIV prevention in Kenya. Thank you, everyone. If there's a question, we can be able to address it if it's been placed in the chat. I want to hand over to Bernard. Thank you.
Thank you. Thanks a lot, Doc, for that nice presentation. So if you have any question, kindly just type it on the text area. We'll be able to progressively respond to your questions as we move on. Yeah, so the next facilitator will be Patrick Gichuvi, who is going to take us, is going to guide us on the data validation and verification process. Yes, Patrick.
So good afternoon, everyone. Attendo, you can confirm whether you can hear me.
Yes, I can hear you. Maybe I could ask Dr. Mutoka to just stop sharing his screen, so then maybe you can share yours if you have.
Perfect. So I'm going to start with the Migration Toolkits. I just want to explain what is there, and then I will explain the simple steps of migration, what we have documented of what you can do. Within that steps, there is a document where we have documented all our assumptions and decisions we have made. And Munene will take us through those decisions, a highlight of the decisions. Then there is an Excel sheet that had been shared with you on how to document some of the findings, what Mudoga has talked about, and then we will end that. So I'm just going to share my screen to show you some of the content that you already have. I believe you can see my screen. If not, please let me know. So So on the screen, I have the Migration Toolkit version 1.1.0. So this toolkit, you have interacted with it previously when we were doing the testing and correcting feedback. So for this controlled migration, we have updated the transformations. So you can see we have the transformations. They are called transformation version 1.1.0, which you will pick and unzip and replace in your PDI tool. We have KenyaEMR 17.10 migration package, version 1.1.10. So this one has some of the KenyaEMR modules updated to cater for the data. So you will need to update your KenyaEMR version if you've already updated. We have done a few changes in IQ tools. So this IQ tools update before migration is a script that you will run in your SQL database to allow you to have a few changes, and it will update your version of IQ tools with one. Then finally, we have some release notes that document what is it that migration is doing. So in a nutshell, those are the 4 tools that we have. Secondly, please note that we are using DWAPI. The reason for DWAPI is for us to be able to track the snapshots of data before and after migration. So we have a new DWAPI that would allow you to upload data before migration and after migration. So we will have a new docket which comes pre-configured, and it will you'll be able now to compare your data before you migrated to KenyaEMR. So if there is no question, I will go straight to the migration process. Just a note, when you do for updating DWAPI, you just update the same way you do. You just click the update in your computer, and it'll pull a new version of DWAPI. And after that, you can go to Spot, and you'll be able to see this migration docket. I hope you can see my screen on Spot. There is a new migration docket called EMR migration, and you'll be able to see your facility there. This one will show you countrywide how many sites are being migrated and what is the progress of that migration. We are continuously improving the Spot to provide more metrics of this migration. So that is on the tools for migration. On the process, I will just rush through these steps. So step 1, of course, is to make sure you have a backup just in case something happens to your migration process and you might need to roll back to your IQCare version. Secondly, make sure you have upgraded your IQCare to version 2.21. We have version 2.21 patch 2 in GitHub. Please ensure you have this version because the migration is based on these versions, and otherwise you will have a problem. If you are using HTS in your facility, you make sure all the other users of HTS mobile apps, Afya mobile app, have synced their data, and the data has left, and you can generate a HTS lab register to just make sure that all the data has been synced. After that, you need to refresh your IQ tools. Do another backup of IQCare just in case. You remember this backup we did before upgrade and after upgrade. Then after that, you will need to familiarize yourself with the migration assumptions and actions. These are things that we have encountered when we were preparing this migration toolkit. We have come across several scenarios, which some of them Dr. Mudoka has alluded to. And at this point, I would want us to go through them, and I would invite Munene to take us through that. I'll stop sharing. Then after he's done, I will resume and complete this.
Afternoon all. This is Evans here. I'll be taking us through the assumptions and decisions made during this migration process. Just to reiterate what Dr. Mudoka, Jacob, and Patrick have said, that this document...
sorry, Evans.
Yes.
Could you slightly zoom it out? I think it is. They are too small.
Okay. Is that okay?
One more. Yeah, that's okay. That's okay.
Okay. Thanks, Ben. Thanks, Bernard, for that. So I will just emphasize and say that this document has tried to get to capture all the issues that might affect the migration or the processes in the toolkit to ensure that the whole process is successful and any decision made is met with some underlying or behind decisions towards that. So it's quite a big document. It's an 8-page document. I'll try going through some of the major or critical decisions, but this document will be shared eventually to all of us for them to be able to go through it and read it as before the whole migration undergoes. So maybe it's divided into 5 key areas: the scope, the findings. These are the findings that we found out during the whole testing process, the assumptions that have been made during the migration process, and the decisions that have been made towards these assumptions to ensure that a successful migration takes place. And then we look at the implications for these decisions, for these to be successful. So maybe going through the first one, just to take you through. If you look at that, the finding was that the UPNs, some UPNs in IQCare have special characters or do not conform to the 10-digit format standardized by MOH back while I think in 2016. So this majorly goes back to the blue card data. So one of the key conditions we have is we will not undertake, the toolkit will not be a data cleaning tool. And for that, data will be moved as is to the other system. One of the things that you have to note is currently in KenyaEMR, you cannot put more than 10 digits. You cannot input letters. You can only input numeric values, which have the first 5 digits as the MFL of the facility and the remaining 5 as the CCC number. So one of the other assumptions that we are going to make is that you will have installed the latest version of KenyaEMR on which these validations have been relaxed. If you use the older versions, these will not be successful for that to happen. The implication for this is the UPNs migrated will not conform to the MOH standard or format. So I will go on just selecting a few of these that might have big implications during the whole process. If you go to maybe something like HIV enrollment, there are patients in some IQCare sites with more than one identifier. That is the value of CCC number. We realize this might be having from the phase 3 or 2 of migration, where some of these records had more than one CCC. So we decided to use the most updated CCC records, which in most cases from our analysis conforms to the set MOH standard, which is the MFL plus NINI plus the CCC number. The implication for this is that there is inherent data loss for the other numbers, for the old numbers. This comes from that KenyaEMR cannot pick multiple CCC values for this. So you cannot migrate these numbers as they are. Just going down, trying to look at which other that really affects us a lot, though all of them are important, and we hope that you will go through the document to try and capture most of them. One of the things I'll just note as we go on is that this is a living document, and whatever you see here is not the final document. It will keep on getting updated as the days goes by. So if I'm just trying to go down and find which other one, like this one, the patient treatment events and or regimen history, what Dr. Mudhoka had alluded to. So if you realize currently in IQCare, IQCare as a system allows the manual input of drugs, not really conforming to the standard regimen as is as given out by MOH or as is in KenyaEMR, and these had led to us having wrong mappings in KenyaEMR, which has a standard way of giving out the regimens as they are. For this, the project underwent several steps to ensure that this comes to be. So one of them was like how the order is. And as you can see in this example here for triple molecules, we assumed that the order of drugs in a given regimen for triple molecules is the same. That means the order does not affect the kind of drug given out. And the decision for this that came out, and this was just not based from us internally. We had also to ask out to the clinical leads from the various leading organizations, that's NASCOP and CDC, to just say that the order of a drug regimen does not affect what the kind of drug that is. So this has aided us in trying to make sure that the regimens in IQCare are the same as the ones in KenyaEMR. The dual molecules, they were mapped to the most feasible third molecule. So the issuance of these molecules is also going to be restricted in KenyaEMR. So the implications for this is that incorrect mapping for cases with more than one frequency and additional data cleaning initiative in KenyaEMR will be expected after migration. This falls back to what we had earlier said, that the toolkit will not be used for any data cleaning activity. It will just be used to migrate the data as is and ensure that the data sits well in KenyaEMR as was in source without really affecting the structure or anything. So I won't go through all of them. I'm trying to just scan out the ones that majorly affect us. And I'm sure that some of these decisions that you see here and assumptions will be captured in your feedback, where you will raise some of the things you have noted while migrating this data. So I look at like this for data quality, duplicate patient records in IQCare. So the duplicate record, the assumption is duplicate records can only be duplicated at the facility level due to the decisions that have to be made on the data, whereby the verification must be done before a patient is merged or before a decision is made, whether these are duplicates or not. So per earlier guidance, the decision that has come is the migration tool or the toolkit shall not be used to either deduplicate or clean this data. So the decision is the data shall move as is. No change will be done to it. This can only be done either at source or at target. And our hope is that the implication for this is that the duplicate records that are in Kenya are in IQCare, if not cleaned, will be migrated as is in KenyaEMR. Hence, the duplicates will also be available at the KenyaEMR level. So illogical data in IQCare. So data cleaning will be carried out in Kenya. Data cleaning will be carried out in the KenyaEMR, which is the target system. So the decision here being the integrity of logical issues to be handled in KenyaEMR. This is just to maintain the integrity of data from source. We don't want to affect how the data is from source during the migration process. Of key importance is like the key dates for Sentinel events. So you will note that currently in KenyaEMR we have some what we call verifications that are done. Maybe you cannot start at the start at date cannot be before the enrollment date and such things. So the toolkit will not be used to verify this. This will also be moved as is to the other system. KenyaEMR will not be checking for such events. The only problem now will be when you go to the encounters or the specific encounter forms. That's when you expect to find the issues arising from logical errors that have been migrated over to the new system, being KenyaEMR. Maybe the other important part that we might have found was how the computation and logic calculations are. That is how the age bands are rounded between the different systems. So you will find for data reports in IQ tools, a 17-year-old with XX months, where XX varies from 1 to 12 months without the months being complete, equates to a 17-year-old, while in KenyaEMR, 17 years and 6 months equate to 16 months plus equate to 18 years, and 17 years and under 6 months equate to 17 years. So if you realize these will give us some problems when you go to reports based on how this has been defined as. So one of the assumptions we made is this represents inconsistencies in the age variables for the two systems, and is only affecting the age band segregations in reports, because these are logical issue. So the decision made was that we'll migrate the data, not the logic, and the implication will be the age bands might not match to 100% as they are, but the totals for the listed reports should or will match as is. So you might have realized maybe when you're running your 731 report, maybe current on art report, the age bands that usually are in the report do not match to 100%, but the total is matching to 100%. So this might be the reason why. This should be the reason why. So the only way to get this is through getting down to the line list and identifying it. Yet on the user interface page, we also noted some differences where KenyaEMR, if you look at the user interface page, 17 years with XX months, that's from month 1 to month 12, without having complete, will equate to 17 years, the age on the interface. While in IQCare, the interface, the reverse happens. 17 years with over 6 months equates to 18 years, under 17 years with under 6 months equate to 17 years. So this one rolls back when you reach half. The implication on this is just how this is viewed. Nothing changes with that. This doesn't affect the date of birth. The date of birth is the same and is moved as is. So on strategic information, this affects the computations on some of the reports, where on date team computation, we realized both systems uses 30 days after TCA, which is in contrary with how the MOH is. So I don't think there's so much discrepancy there between the two systems, only that the implication is if you compare this with the MOH reports, for TXCAR, the indicators in the facilities may not match because of the 30 days addition after TCA for calculating the TXCAR. So where we are even focusing most is how the MOH that one comes out for both IQ tools and KenyaEMR. The major findings are that in IQ tools, prescriptions are used to calculate the current on art, and current on art is a function of the number of the days drugs are dispensed and not the TCA. For TXCAR, it's usually 0 days for TXCAR from the date of TCA for them to be effective in a certain month X, and the TO is effective from the next TCA date given out. In KenyaEMR, uses TCA to calculate current on art. So since we don't have the prescriptions in KenyaEMR, current on art is a function of TCA date. 0 days for TXCAR after TCA, which is the same, and the TO is effective immediately once the form has been filled out. So the assumption that was made here, there's a relationship for expected return date from both the listed TCA in AMR to the addition of number of drugs dispensed from the last prescription date. Remember, this is just an assumption. The decision was that was derived from this. We use the existing TCA date in IQCare, but we have a condition here. There are two conditions. One, when the TCA is not available, we should compute the prescription date to form us, to give us the new TCA date. This was realized that in some scenarios, as written here, clinicians rarely input the TCA date. They assume the prescription date will be, or the date that the patient is coming back is the date that they will also get to see the clinician. So this has been fixed. The only problem with that will be some discrepancies within dating reports for TXCAR indicators, as earlier explained. TXML will also be affected in cases where a patient had a TCA for 1 month, but a prescription of, say, 60 days. So they will be deemed as a defaulter in IQCare if the TCA passes without a visit, but they will not be a defaulter in KenyaEMR, as the calculated TCA is in 2 months from that time based on the prescription date, which is 60 days. So you realize that we are keeping on identifying these findings that really affect the output or the expected output in the target system, being KenyaEMR, and we'll keep on expecting that you plus us will keep on beefing up this document to ensure that whatever the experience is using the toolkit is documented well to avoid after migration issues resulting from the migration. We'll be able to capture all incidences and know that what each incidences means to the target system, or in KenyaEMR after migration. So of importance to note is that this document will be shared to all of you. I haven't gone through all of them. I've just sampled out some of the key assumptions and decisions from the findings we've gotten. And these are the ones that majorly we know affects the whole process in the end. So Patrick, I don't know if that was clear enough. And the rest of the team.
I think it's clear. Did you mention on the new and TI details?
Not really, I did not mention that, but you can take us through over that.
I think it's important. You can just scroll up a bit. It is very widely spread. I had seen it in the list. Basically, it's a case of where we have patients who are new, who are marked as new, but they have TI details. So on that one, the decision was to migrate them as they are. So you will find, if you go to IQCare, you will find a new patient, but they have TI details. So we migrated that data as is, and we provided a query that can show you those patients, just in case you need to know why before you migrate. So that's the only addition I wanted to make on this presentation by Munene.
Okay, thanks for that. Thanks for that. So I think you'll take over from there and continue with the remaining parts of the same presentation. Thanks all.
I'll continue with the presentation. So basically, we have finished on item number 6, where we have gone through the assumptions. We are still revising that document, and we'll update with any findings that you give, share with you the document. You can reach out to Otieno to get a copy. So after that, I would want to present the migration document. I hope you can see it. It shows you what Mudhoka was taking us through. So this is just a documentation of the aggregate and patient level data. It's pretty self-explanatory. So you will generate the report before and after migration, and then you will be able to document these indicators. You'll check on the age disaggregation, the number of patients, whether they are in both reports. If there is an issue, you can try and diagnose it and document it, whether it's data quality, computation, or logic, or a toolkit issue. Then you will provide a short description of your finding, and finally a proposed way forward. If you have, it's optional, but you can give us your finding and what you think we can do to address it. So these are a list of some of the indicators that Mudhoka had mentioned. So this is at aggregate level. This is at patient level. Basically, things like date of birth, registration, enrollment, diagnosis, appointments, vital signs and BMIs, chronic illnesses, everything basically to do with mostly care and treatment, to just document whether the patient are the same. When Otieno mentioned about boardroom migration, so we are expecting that you'll be able to have the two EMRs open on in your office, and you can compare one-on-one per patient, open the profile of one patient and the other migrated patient, and check what are your findings, and document those findings here. And if you feel that this is not sufficient, you can still explain your finding, and you'll be able to analyze this data for the controlled deployment sites. So for you to do that, you will need to have generated the reports before migration. That's why you are refreshing IQTools and save them somewhere. Once you've generated all the MOH reports and any other line list that you normally use, you will need to do an upload of DWAPI. Once you go to the new DWAPI, you'll find a new docket called migration. You still need to upload that. So you'll do the 3 normal dockets. That is, if you have HTS, you'll do care and treatment, MPI, HTS, and migration. And after that, you will follow the SOP on how to set up the migration tools. I'm sure you have that SOP. I didn't want to put it here because it will be pretty long. Then you will undergo the migration. Please record the time it takes you to move from the beginning to the end. And then you refresh the ETL. And this is pretty lengthy process, and you have a separate SOP for that. Post-migration, you will generate the same reports you had generated in 8 above. This one now will inform you and help you to fill the feedback form. Then you'll set up DWAPI in the migrated site. You will upload the same number of dockets that you had done pre-migration. And after that is where you can now be able to fill this migration form, because you will be having both the post and pre-migration. And then you can compare and contrast and document any findings. After you've done DWAPI upload, you can go to spotting DWAPI spots, and you'll be able to see the output of your migration. If you are in the office and you have people who are migrating, you can still go to spot, and you'll be able to monitor the progress of migration of your sites. So in brief, that is our presentation. I don't know whether there are any questions.
Yes, thank you very much, Patrick, for that. I guess I've seen questions are coming up on the chat area, and we are responding to them as we go along. So I think for the sake of time, let us just post our questions on the chat area. We'll be responding to them. So I think it's good if we move to the next session. So this is particularly for our partners. We are going to kind of give you a chance to just give us your feedback, especially on the testing of the migration resources that were shared with you last week. So Ajuang Bernard will be moderating this particular session for us. So Ajuang, if you are on, kindly just take over.
Yeah, sorry, Bernard, just as Ajuang is preparing to show, I think you'll notice that we are kind of shifting gear a little bit. We are not just focusing on we are focusing on both reporting variables, individual level data, and upload to the national data warehouse. So we are looking at this migration process not just as a validation exercise, but to look at the whole migration kind of comprehensively, so that as we go into controlled deployment, you are confident that your reports will work. Individual level data uploaded to the national data warehouse will have the integrity maintained, and that when it reaches the other side, we can actually be able to validate that they are happening. So as Ajuang is going on with that, we also need to start thinking about the actual migration process. You know, what will it really look like in the facility? I saw a question earlier, what is this boardroom migration? You know, how will migration actually look like for you as a partner? So that as we go through this process of getting feedback, we can focus on what Ajuang will take us through, but also start thinking beyond that to the actual migration. Over, back to you, Ajuang.
Thanks, Doc. I'm going to moderate on the partner feedback session. I do not really have a presentation to make. I'm just going to ask the partners for their feedback as they were testing with the builds that were shared last Friday. So the order I'm going to take will be based on the work plan that was shared by Otieno. I've been informed that CHS Shinda Kenny stepped out for a minute, so I would want to start with Naishi. My request is for each organization giving us their feedback, please take about 2 to 3 minutes because we've got 10 partners, so that should be about 20 or so minutes. Then we can move on to the next session and then we close in time. Thanks so much. So I would request at this point the representative for Naishi to just take the floor and give us your feedback. The only other comment I want to make is that we expect your detailed migration test results on the template that was shared. So at this point, we just want kind of a highlight and an overview of the experience, any specific issues that you'd want the developers to focus on, and the QA team and the rest of the control partners who are testing at this point. So Naishi, please take the floor. Hello. So for Naishi, is that Marianne presenting?
Maybe she's on mute.
Okay. So I hope we won't take much more time. So after Naishi is Tegemeza, and then next would be UMB Endeleza, and then UMB Timiza, in that order. So Naishi, please. May I request that we skip Naishi? Tegemeza, are you ready?
Hello, good afternoon.
Hi.
Yes, Kevin, you may go on.
No, I think it's okay. You can present. Huh?
Okay, now, my name is David. I'm representing Tegemeza. And I can say we've had a good experience trying and to do the migration, the test kit. Initially, we had challenges using the old toolkit, but our major challenge was on the data discrepancy. So far, with the new toolkit and the new resources that have been shared, we've not had a major issue. We've been able to go through the whole process, including the data validation. And at least I can say finally we've not had major discrepancies in our data. But probably due to time limitations, we could not have done everything on the controlled migration templates. But at least we managed to do the 7.1 and datum. Yes, I can say the discrepancies are still there, but not a major one, particularly on the TX current, current on ALT, and on CTX. And we hope in as much as we give these feedbacks, we'll also be able to get feedback on what could be the issue with these indicators. And I hope all be well. We have been able to do migration for both Kirora Health Center and Maragua Ridge. I don't know whether we are supposed to share the data or just the highlight.
Thanks, David. I think that highlight is very much appropriate. We will be looking at the detailed report on the template. So thank you so much. That is a report for Naishi, right?
That was Tegemeda.
Tegemeda, sorry. So Naishi is
Yeah.
Yes.
So I wanted to just find out as before we move on from there, did you manage to use the validation tool, and what was your experience?
Yes, we managed to use the validation tools, and like I've just said, we've not encountered major problem except the few discrepancies. The indicators that are put there are right, and the template is just perfect for validating. So the experience was okay, except now we need to know why the discrepancies are coming in. Yes.
Yeah, so just a quick question, a follow-up question. Was the tool able to help you identify the cause of the discrepancies, especially if you looked at the records that were being dropped or added on the KenyaEMR side? Like if you were to look at the variables that are relevant for reporting, were you able to identify the reasons why?
Yeah, the tool was quite helpful in trying to drill down even to the patient level information. And I think a number of indicators you're able to know the issues ranging from data quality, things like virologic issues. We have not really been able to drill down to that, but for a few data quality issues, counter-checking on both the systems, we're able to see where the problem is. So I think the template really serves the purpose. Yes.
Okay, next. David, thank you so much. Kevin was up next. Kevin?
Yeah, thanks, Bernard. So actually, David has presented what I wanted to present, the one for Tegemeza.
Okay. So then we go to UMB. I would like to ask, is it Kibonye for UMB Endeleza? First Endeleza?
So, thanks, John. I'll give just a quick summary, and Duncan will give a more detailed report. So the tool is working, except for the discrepancies in patient numbers. So the numbers that are in IQCare, others are missing in KenyaEMR and vice versa. Then also there's a discrepancy in terms of the concordance, specifically for PVLS, that is numerator and denominator. Yeah, and also there was also a discrepancy on client on CTX. But so far so good. There's a significant improvement.
Thanks, Kimonye. So next is Duncan to give us additional details from Timiza.
Yes, thank you, Joan, for the opportunity. And first of all, I would want to commend the Palladium team for the tireless work that they have put into this, and generally the entire team that has been working on this, giving feedback back and forth. So far, there is much significant improvement, but as Kimonye has said, we've done a migration as a feedback with the detail bit. Hello, can you hear me?
Hi, Duncan, we lost you at some point there. Do you mind just recapping?
Okay. Okay, whatever I've just said is that I'll share the detailed information because time might not allow.
Okay. Okay, so I think
Kimonye has given is
okay, so I think we have the details from UMB Pact Endeleza and UMB Pact Timiza. We'll get the detailed report to be shared by both Endeleza and Timiza on the document. So next, I would like to ask Afyanyota Kaunda, if you're on the line, please.
Yeah, thank you very much for this opportunity. On behalf of Afyanyota, I'd like to give a feedback on the process so far and what we have done in regard to the migration. So we have had tested the data, for a couple of sites. In the lastly shared updates, which were shared on last week on Thursday, we managed to do BCIL Health Center, and the results were quite good. We managed to do 100% concordance for 3 indicators, and amongst those are TXCAR and TXNew in both DATIM and MOH 731. We had issues with the TXPVLS and also clients on CTX, and we are still finding a way of getting, or rather drilling down and getting to understand the cause of the variances across the 2 systems. Maybe the request to the team, I know they have shared a good template on how to do the validations. I don't know whether you can assist us by going further ahead and doing a common query. I know you're busy trying to work on the other bits, but maybe some common procedures on how to do these validations across, especially for across the 2 systems at patient level, so that we don't do things differently. Yeah, maybe another thing or a request that I can have to the team is I noticed that in the event there is a failure during migration, especially importing data to the KenyaEMR part, it's like you may need to repeat the entire process from the point of installing the KenyaEMR migration package and then start the importing bit. I don't know how difficult it is to put a provision in the migration kit, maybe to resume from some level, just the way the different data tables are normally listed while migrating, so that maybe somebody can resume from some point, something of that sort, because I see it being maybe a bit expensive when doing large databases, and then you have to repeat the process again. So I think that's what I have from Afyanyota.
Okay, thanks, Kaunda. Do we have any reaction to Kaunda's suggestion? Is this something we can ask? I think your second request for provision for resumption during the migration, during the loading process on KenyaEMR, we'd ask the dev to consider that if it's possible. If it is a tall order, perhaps we might just want to work with it as it is. And then the other request on a common validation procedure, we'll want to see if this can be harmonized. I think I'd want to ask Patrick Gishuki, do you have a reaction?
Maybe we can provide a simple guidance, but for the patient level, preferably during the boardroom is where you're able to do that, because you can have both the patients open. Maybe we can provide a guide of the particular interface you need to go, but in my expectation was you just open a patient in IQCare and open a patient in KenyaEMR. Maybe the only guide we can provide for you is where to go. Maybe you need to go to charts to check this indicator, or you need to open a visit to check IPT. We can do a small guide on where you need to check for any of those indicators. Yeah.
Thank you, Patrick, for the guidance. So next we get a reaction from Afya Kamilisha on their testing results.
Good afternoon, all. So Eric Mudhomi will take us through that.
Hello, good afternoon. I think everyone can hear me. Hello. I'm giving feedback for Afya Kamilisha for what you've been testing. My name is Eric Mudhomi. And first of all, to start with, is to thank the Palladium for this support that they have offered to us to advance this migration. So I'll take a few minutes just to highlight some of the feedback that I have from the template. That is, we end concordant data in the enrolled in care, the starting ERT and the current on ERT, whereby the data that is and the KX and the for the part of the second one that is on the retain data, we have a concordant data. Upon checking the discrepancy that we had under the current checks car, that is for the day team, I've noticed that some clients who are both are also active in the team, but when upon generating the line list in the IQCare, the client is omitted. But upon checking the forms, the client has all the forms, the client is active, the pharmacy in the IQCare was filled, even the other forms. But now upon coming to the report, we cannot be able to get the client. But that's not making us be able to get the discrepancy. Then the other, I've managed to highlight 6 patients records, both in the IQCare and the KenyaEMR, whereby the reports were turned. So far, that's what we've managed now to get, but we'll be able to work through validation and filling.
We cannot hear what he's saying.
So I think because of time, we will give the detailed report, because I think at the location he is, the network is not so good. But you're going to see the feedback once we send it. Thank you.
Juan?
Hi, Otieno.
Yeah, I think
let's go on because of time. He has some internet issues.
Next partner, please just let the partner come on board so that we proceed. There's no time.
Okay, do we have Amref?
Yes, Bernard.
Yeah, please go ahead and give your overview of the test result.
So thanks, Bernard. Concerning us, I think with upcoming sessions, we are going to be giving more detailed report. We are still scrutinizing the reports based with the toolkit that you shared. So far, we have managed to migrate 3 sites, which is we had started actually before the site was taken. The site which was proposed was taken. We had taken 2 of our sites who have more than 2,000 active patients, and the migration has been successful. So during upcoming sessions, we'll be giving more details. But one of the things that we have found out in terms of the TX current, there is a concordance, because that's one of the areas that we first checked concerning about that line list, doing the line list and also doing the report based on the TX curve. So the concordance was light for one of our sites, which was community. But now the site which has been taken, which has which fit to the criteria given with the DESA patients, previously it was running well, but for the current, we used the toolkit which was shared last weekend, and we had a problem in importing in terms of doing migration, whereby there's a table for hay tables. There was an error of which we shared, and it being sorted. So that's one of the error issue that we encountered while doing the migration using the current toolkit which was shared. Then maybe another challenge we can talk about is about the time taken during migration, because one of those sites which has more than 2,000 patients, to be specific for community, it took 237 minutes. So that's about more than 6 hours. So maybe that's one of the areas maybe we can talk in case I don't know about the current toolkit which was shared, whether the time frame will be more minimal. Then the others of one of our sites had a customized forms there before, so it brought up some error during migration, and maybe those are the other areas that we might sort while doing migration to those sites. But during upcoming sessions, we'll be sharing more details once we use that toolkit in terms of checking the concordancy with all the indicators within that toolkit.
Okay, thanks, Kennedy. So second last, could we have Afya Jijini?
Good evening. This is Rajab speaking from Afya Jijini. First of all, I'll start by thanking the Palladium team for the good work that they're doing to us to ensure that we are migrating to KenyaEMR. So to share my experiences, I've managed to migrate 2 sites using the new transformation that was shared on Friday. And some of the findings that I noticed when comparing the two reports from KenyaEMR and IQCare. So for one of my sites, notably Kayole 2, I noticed that there was a variance in TXCAR. That is, on KenyaEMR, I had a higher figure than what I have on IQCare. The same goes to quarantine care. For my other site, St. Mary's, there was not much variance, as I just had a difference of 4 between the TXCAR, where I had a bigger difference was in quarantine care for St. Mary's. So due to the time that I had, I wasn't able to dig deeper to see where the issues were coming from. But by end of the day, I'll try and go through the files one by one and see why is it that on one site there's not much bigger variance, and on another site I have a bigger variance. But generally, from the use of the tool, I'd like to say that the tool is not that difficult to use. I got help from both Kezia and Leon, and I very appreciate, and I was able to migrate and validate. So from my end, that's what I can share for now. Hello.
Yeah, thanks so much, Rajab, for that. May I ask if Kennedy Wambua is back on the chat? Kennedy? Okay, so we can't get Kennedy. I'd just like to give maybe I'd like to take 30 seconds to say I was working with the CAP team. CAP is one of those sites that were formerly using IQCare SI version. So we got some last minute transformation files that we used to migrate today in the afternoon. And so I can report that the current version is now working well for the IQCare for their sites. So they will be sharing the detailed reports later. I know Rugut was not able to share his plans. I know also Wambua has also done tests, but he is on off and is on and off this connection. So I would like to say, I think that marks for us all the partners.
Ben, unless
yeah.
we add something from KCCB.
Yeah.
Yes. Now we are still wondering or asking ourselves the difference between the TX current and the current on RT still needs clarification for this. And also on part of KenyaEMR, we're not able to generate the line list, especially for TX current. Yes, for current on RT, we are able to generate the line list for current on RT. So if also Benatiano can guide on how we can generate the line list for the TX current. Yeah. And then also on the migration kit, the last ever shared migration kit is giving problem. It is migrating up to around 56%. Then it gives the message that it has successfully migrated all the data sets. But when you go back now to the reports, you are not able to generate the reports. That's that's another observation. And then the other thing is that yes, it is taking a shorter time than the former migration tool. Though now also looking at the data sets, the data sets available are fewer numbers compared to the former migration tool. So for us now, from what we have generated is we can say the second last migration tool which we have used before the last ever shared migration. The one which was shared on a Friday is not giving the correct result. Yeah. So that's the feedback.
Okay, so I think before I let Doc speak, Darius, there was a final file that was shared with us today over lunch hour, and that is the one that I had asked Rugut to use to transform. I did a parallel test with one of your sites, the Rango SDA, which previously was not working, and now it's been able to go successfully. So please disregard the Friday setup. There is a file that you need to replace there and run the PDI again, and then load KenyaEMR. You should have everything in order. So I think we'll talk to you after this particular meeting.
Yeah, we'll follow up individually with what we have done. Yeah, then it let you know what how it is.
Hey, see you.
Okay. So I would like, at this point, I would like to ask Dr. Jacob to guide us on the next phase. We had previously planned for each partner to share their plans during this call. However, we recognize that the personnel who are testing would not have all this information at hand. So we would request that all the 10 partners reach out through their supporting SECA to share their complete rollout plans in the course of the week. So I think Dr. Jacob perhaps can guide us on a timeline by which time we can get the rollout plans by each partner, even as the partners complete the testing. Thanks. Back to Dr. Jacob.
Yeah, so I think for me, the first thing, I know the weekend was such a short time, and some of you actually have put in extra hours to just get the outputs we are reviewing today. I just want to close that session by appreciating the work you have put in and the feedback we have received so far. So far, I've seen our team are documenting some useful information to help us identify why the discrepancies. At this point, I would really suggest that we don't look at this as just validating the toolkit, but preparing those specific data sets for migration in the controlled deployment phase. So any issue that is identified needs to be drilled down into great detail so that we identify the root cause. And I think that is why we shared the template. We are quite interested in looking at the specific cause of discrepancy. I think in the assumptions and decisions made document that Evans took us through briefly, it kind of highlights some of the possible causes. And I've seen in the chart some other regions have been identified by some partners. I would really encourage you to please just go drill down, use the validation tool as a help, as a guide, but please drill down to, as much as possible, try to identify why for that specific database, the reports are not concordant. We have been trying to do that internally and that is what has helped to improve the tool to where it has reached now. But I think where we have reached, we would really want you to be part of that drilling down. So please try to get at least look at the reporting variables, check. Once your data, check for anything that could cause reporting discrepancies. From the meeting today, I'm seeing TXCAR and current on treatment, the viral loads, and CTX seems to be major culprits for different databases. Would really appreciate, with your experience in the field, to understand why some of these variables are not matching. On top of that, once your data matches, that's not enough. As Dr. Mutoka took us through, just sample some records. I think Patrick explained this when he was going through the validation tool. Sample some records that are even matching when you look at the reporting angle, but when you now start looking at the variables, they don't match. There is one piece that Dr. Mutoka did not mention. When your site is, if your site is implementing interoperability and your CCC number migrated differently, it means that you may not match the same individual in ADT for that matter. So please just try to make sure that your data and those relevant variables also match. If we don't know it, we cannot sort it. If we get to know it, we can sort it, so that by the time we are talking about migration roadmaps, we are preparing these databases as part of that migration roadmap. I would really be looking out to see success from individual sites so that we can talk about moving these individuals to the actual process of migrating that site. The final part of that validation is the National Data Warehouse. Maybe Otieno, you can talk a bit about this, or Koske if he's in the team. We have set up a test instance of the data warehouse for the purposes of checking for concordance in the numbers. So I would really wait. Maybe if Koske is on the call, you can maybe take a few minutes and talk about that, or one other person, so that we are checking these sites from end to end in preparation for the actual facility level migration. Finally, on the plans of course have that we are looking for from partners. We'll have the phase of data preparation for the migration that we are already doing. Then the second part is how will you want to approach the migration at the site, so that we can be able to understand, for example, if you're having two sites, which ones you want to move first and when, and what activities you would like to undertake, so that we see how to pair you with someone from our end to help you to migrate that particular site. And generally, documenting the process and lessons learned, so that by the time we are finishing the 1 month we have allocated for this migration, we can be able to have a meeting where we are giving feedback, and you are the ones actually informing other partners of your experience with migrating during the controlled deployment cycle. So for me, that is basically it. We are looking for roughly just slightly under 1 month to migrate each of these sites, and under intense scrutiny, so that if anything arises, we are able to respond very quickly, address them, and document that lesson before we move into the phase of mass migration. So I think my question is just get back to you guys. You can choose to speak or to type in the chat with two questions. So the first question is, with your knowledge of the site right now, do you think if we give ourselves 1 month, we'll be able to migrate that site and document the lessons that we have learned? And then number two is, how do you think that looks like? And can you share with us your plan? So I think for me, that is the comment I'll just leave you with, as maybe someone talks about the data warehouse piece. Over. Adjuan? Or Patrick, do you want to talk about the data warehouse validations?
This is Duncan. I think I'll just talk about the warehouse and what we intend to achieve during this process. So if you have not yet received, we have a testing, a DWAPI that is used for sending data to the testing instance. So we hope everyone has that testing instance for DWAPI. So we'll want you to load the data first before migrating. So basically you load as you normally load from IQCare, and please send all the dockets. We've made it that you're able to send all the dockets. So we have the HTS, we have care and treatment, and for those who have, we have the PK visa. So please do send us and that data. Then after you migrate, you also send the same from KenyaEMR.
And DWAPI, as you know, is a validation tool, so you can always note those missing validation items. It can be an added step when you're looking at what is exactly is missing. So please do send before migration and after. So this assists us also on the warehouse level, so to have a clear picture of what the data looks like after migration. So please reach out to us if you need any assistance in doing that also. Yeah, thank you.
Okay, thank you, Kosuke. I guess that is pretty clear. But in case you need more information, please just reach out. We'll be able to provide you with the information that you need about the DWAPI and the data submission to using the DWAPI tool during the migration process. So I think due to time, I think we're almost coming to the end of the call. But before we do that, I just want to reinforce Dr. Jacob's questions. I don't know the faster way to do this. We just want to get kind of an idea of how long it will take you to migrate your facilities. So then we can also kind of have a timeline by which this first phase will be done. So I don't know whether just to run through the partners who are here, just because by now we suppose you already have the experience and you know how long it might take you to migrate the facilities that you have selected. So maybe the best thing is just going through each partner, just respond by telling us how long. So if it is 1 day, that's fine. If it is two days, that's fine. So then with that, we'll kind of have approximate end time by when all the facilities shall have been migrated in phase 1. So we'll also expect you to kind of share with us a comprehensive migration plan, possibly through the respective SEC team. They'll be reaching out to you probably tomorrow so that you share with them that comprehensive plan. But for now, I think all we need is just the time estimate. Is it a day? Is it 2 days? How long? Based on the number of facilities that you are targeting for the phase 1 migration. So very quickly, I'll just go through the list. So the first one is CHS Shinda. You have 2 facilities. So how long will that take you?
Hi, for CHS Shinda.
Yes.
Yes, Ken, sorry. For CHS Shinda.
Yes.
You could pick the small sites. Huh? And I believe we finalize on checking all the issues that we wanted to check on, including the patient level information, then we can give ourselves 2 weeks.
2 weeks. Okay, thanks for that. CHS Naishi.
Hello, everyone.
Hello.
Hello, we have 3 sites for pilot testing. So we're hoping within the next 2 to 3 weeks.
Say that again, please.
2 to 3 weeks.
2 to 3 weeks.
Yes.
Okay. CHS Tegemeza.
Hello. So for CHS Tegemeza, I believe 2 weeks will be enough. So we'll target one site next week and the other site the other week.
Okay. UMB endeleza. Okay. UMB timiza. Okay. Afya Nyota?
We are working with 2 sites, so 2 weeks would be good enough.
Okay. Afya Kamilisha?
We are working with 1 site, so 1 week will be enough.
Okay. How about KCCB?
Give us a week. Let me understand. Are you saying from today or just the number of days?
How long? As in the number of days, not from today. But in the report, in the plan
for the number of
share with us, we would want to know when you are likely to begin and when you are likely to end. So for now, we just need the period that it will take you. But then in your comprehensive plan, we'll need to see the starting date.
Then for the 2 facilities, give us 2 days.
Okay.
2 days?
Okay, poa. Hakuna za kujifunga na siku mbili.
Yeah?
Did you say 2 days?
It's consulting.
We'll do the 2 facilities in 2 days. That's 1 day each, because they're small facilities.
Okay. Amref?
We have 1 site. After that terror is sorted, I think 1 week is enough. So this week is enough.
Okay. Then lastly, we have Afya Jijini.
For us, we have identified 1 site, and we have a staff who is conversant with KenyaEMR. So after we get the updated migration tool, I think 1 week will be enough for us for that site.
Okay, thanks. Thank you very much. So I think the pending partners we have are and the LESA, UMB Pact and the LESA, and UMB Timiza. If they have the call, maybe you could just share with us the duration. Okay, seems like they're not there. So I think I've captured that. So we'll be waiting for your comprehensive plan tomorrow. So our team will be reaching out to you, so then you could share with us those plans. But I think the highest duration here is 3 weeks. So I think maybe Dr. Jacob, we could start planning around that, having like the 3 weeks as the maximum duration. But I think then based on the comprehensive plan that we'll see tomorrow, then we can also make further determination. Okay, so at this point, I think we have exhausted much of what we had. So I'll just hand over to Joseph Jume to take us through the way forward and also guide us through the closing session. Welcome, Joseph.
Hi, good evening, everyone. Apologies for this taking a bit longer, and it's not our intention to prolong it more than this. So I think mine is just to thank you for creating time for this. I know there are questions that have been asked, and we've done our best to answer them. And then on the next way forward, as Bernard has mentioned, is just to embark on the migration, on the controlled deployment. And I think there was one particular question that was asking, what is the boardroom migration? I think the whole idea that we are trying, it's more of a recommendation that we try to minimize service disruption at the site. So we'll need some meticulous planning on your part, so that probably the day you are doing the switch over, you don't have like, it doesn't fall on a clinic day. and where possible, maybe you could even ensure there is absolutely no traffic from patient perspective. Then the other reason why we are proposing for that is because we would want to minimize the number of hours you spend at the site doing the migration, because if maybe the loading will take 2 hours and then you have to go install KenyaEMR, confirm everything is working. So we are talking about around three or so hours. It would be easier if maybe that loading or migration was done offsite, so that we just come and do the deployment and restoration of the backup. So the way forward, as Bernard has mentioned, is to undertake the control deployment using the templates that you have shared to provide your feedback, so that in July, I think we are working with around 5th of July, we can have a review meeting where now we can identify areas that need, I think it's 3rd July or thereabout. We can have a review meeting to discuss areas of improvement as we go to mass rollout, because as we all know, vitu kwa ground inakwanga different. So it would be good to use this to test the waters and give us feedback on what we need to change. Are there things on the approach that we need to change, and so forth? Are there new assumptions, or are there new things that you have learned from the data at the site that will require our part from a technical point of view, and also from the overall process of migration? So I think with that, I would add my comments, and once again, thank you very much. Thank you.
Thank you, Joseph. So I think we have come to the end. So ideally, we'll be sharing the materials as has been requested by some of us. So we'll be sharing the presentations and also the assumption document. So then maybe you could take your time and go through them. This particular recording will be shared on our official YouTube channel. So you can just go to the YouTube channel, search for KenyaEMR, and feel free to subscribe. So then maybe you can also get some future updates that we'll be posting therein. Otherwise, at that point, I don't know, Dr. Jacob, if you have the closing remarks before we call it a day.
No, I don't have much to say. Thank you for participating.
Okay. So thanks, everyone. So we'll be reaching out tomorrow for those particular plans. So let's engage further on the WhatsApp platform as you do your testing. And also remember to complete the migration data validation feedback, the spreadsheet. So then we can also see from our end how the concordances are going. So at that point, we'll end it at that. Thank you very much for participating and for taking time. See you again next time. Good evening.
Thanks, Ben.